I've been asked to introduce today's speaker, and I've also been asked to make a couple of announcements before I actually do that. Number one is this is National Rehab Week, and coincidentally our speaker is here today as a result of the efforts of several people in the rehab department. If you haven't noticed, there is a display in the lobby. We certainly encourage you to take a look at that. If you need some added incentive to take a look at it, there's going to be a reception this afternoon at 2:30 with food and beverages, and that's usually a pretty good draw for most folks. Our speaker today is Dr. George Sigel, who for about the past 21 years has worked extensively with chronically mentally ill folks. Don't worry about the shaking, it's just cold in here tonight because I'm nervous. He serves as on the professional advisory board of the National Alliance for the Mentally Ill. He was the founder and director of the West Broadway unit at Bay Cove Mental Health Center and continues to work there with the Medication Support Clinic. He was the medical director at Metropolitan State Hospital. He was the chief of psychiatry at Bridgewater State Hospital until he became the admissions director there, which is the position he currently holds. He's going to be speaking to us today on violence as a form of social contact. So without further delay, Dr. Sigel.
Thank you. Is that right? Okay. I'm really delighted to be here. I grew up in New Hampshire, so I feel like I'm coming home. New Hampshire is really never far from me, and I do have some family in Manchester. The subject is hard, obviously, to cover in a meaningful way, certainly in an hour and a half. We have at Bridgewater, and will now be having April 1st and 2nd, our 5th annual Study of Violence conference, where we literally take 2 days out of the year to really try and study violence. I invite you all to the conference. Perhaps I'll make a point of sending you some of our brochures when we have them ready. It's obviously a very important topic because I think we're all nervous about the potential for violence that our patients may demonstrate. And I think that there seems to be the popularity, for example, of the Bridgewater Conference certainly seems to suggest that there's a broad-based anxiety that clinical staff have, whether you work in a nursing home, a community residence, a state hospital, or an emergency room, and in private practice. And I do think that people are curious about strategies for interventions where the potential for violence can first of all be recognized and then secondarily kind of understood. And I think without understanding it in some kind of a clinical context, it's almost impossible to develop strategies for intervention. I do have a point of view, and I think I'll express it first, because I don't want to be misunderstood. I'm not soft on crime. I also think that when people are violent, there should be a consequence. I don't think that we should understand it away. I don't think that we should necessarily withdraw from imposing the appropriate criminal sanctions if in fact one's violence has resulted in some criminal activity. But in trying as a psychiatrist, as a mental healther, to understand violence in a clinical setting, you run the risk, I think, of being perceived as someone who's trying to kind of explain it away and basically use empathy as a vehicle for making victims out of perpetrators. And I think the observation that so many perpetrators were at one point in their life victims doesn't go down easily on lots of ancillary staff, certainly, and sometimes clinical staff as well, who are working with you in some kind of collaboration around the mentally ill, who tend to be, at times at least episodically, violent. There were 3 questions sent to me that I would like to just briefly address. But first, my point of view. And that the majority of the chronic mentally ill patients who tend to be violent don't like to be violent. And I think that's an important observation, that for the majority of them, it's very dystonic. It's very upsetting to them. Following an episode of violence, the majority of the chronic mentally ill individuals are very upset with themselves. Paradoxically might at that point be even more dangerous because they're so upset with themselves. But it certainly has been my experience over 21 years that the majority of people who have a chronic mental illness and who are violent really don't like it, and in fact invite, despite their initial resistance, invite interventions. And I think that, for me, then suggests what really is the opportunity. Because if, in fact, what I just said is so, then it's not as difficult as one might imagine to begin to develop what we call a therapeutic relationship with these individuals, where the goal is to sort of say, listen, there's violence here. What can we do together to understand what are the precursors that lead to that kind of acting out? And in fact, it's been my experience that the majority of patients really welcome that kind of an approach and are very responsive. And indeed, following the initiation of such a process, in fact, the violent behaviors diminish substantially, if not entirely disappear. So the first question had to do with suggested interventions that can be used to decrease violence, especially the role of adjunctive therapies. Well, again, it's my point of view, but before we talk about adjunctive therapies, and certainly whatever that means, we can talk about it, but I think we can't discard garden variety conventional psychotherapy. And I suppose here again we're back to my point of view, that if you don't have the beginning of a relationship with a patient, you're in trouble, and it's guesswork after that. And that's true whether your primary mission is to prescribe medication. If you're not sensitive to the resistance, you're not sensitive to the issues, if you haven't attempted to develop a bit of a relationship with someone, you'll have non-compliance, or you'll end up forcing medication more often than really seems clinically warranted. So I think that patients have to experience you as moving toward them. And I'll tell you a story. I've never told this story publicly, and I was driving here thinking, well, you know, why not? And I think, to some extent, I think when any one of us is a victim of violence, there tends to be a degree of shame attached to it, and it's almost like, I don't want my colleagues to know I got hit because they'll think I did something wrong, you know, that technically I goofed, you know. But I have been hit once. And I'm sort of proud of the fact that I've only been hit once, but I'm going to tell you about the sort of the situation that led to my being assaulted. Basically, it was an evaluation of a man who had been doing, just you may know him actually, he had been doing a lot of not guilty by reason of insanity time at our state hospital in Massachusetts, because many years ago he had murdered his father. And every year, on the anniversary of his recommitment, he obviously regresses into a more fulminating paranoid psychosis. He tends to be more irascible and can, in fact, get into scuffles, nothing serious, but scuffles with other patients. Well, on this particular morning, I was in a rush. I was doing my evaluation of him sequentially, you know, with other patients that I had to similarly evaluate. I was not paying attention. I was looking down at my notes, totally preoccupied with something else other than Mr. R. Mr. L, really, disguise it. I literally was not looking at him. I was talking to him, but really not paying attention. And I obviously was not paying enough attention to the fact that he was very tense. I was overlooking the fact that he had a court hearing 2 weeks away, but had already been served notice. So this was, again, one of those anniversary times. And I'm not blaming myself for the fact that he hit me, but I know in retrospect that had I been moving toward him and not moving away from him, I would not have gotten hit. Had I been more sensitive to the fact that this was an anniversary time for him, that stirred up issues. His father was not a nice man. His father was very intrusive into his life. Doesn't mean his father should have gotten killed, but one can understand the kind of hostility that was generated out of years of devaluing and intrusiveness. And in some small way, I was recapitulating some of those dynamics. Had I been basically more sensitive, had I been more aware, but I think also had I been able to move toward him that morning rather than to be distancing myself because I was just totally not there, I think I would not have gotten hit. And I think that's very important in terms of an intervention. Patients, violent patients, if they experience you as wanting to be there with them in a kind of psychoanalytic sense of that term, if they sense that you want to be helpful to them, whatever that means, that's very important to them. On the other hand, if they sense that you're preoccupied, that you're withdrawn, that basically you're not interested and that you're going through the motion, I think you have a situation there where there can be potential for difficulties. There are obviously many other interventions, but again, short of developing a minimal degree of rapport in the first interview or two, if you recommend medication to the majority of these chronic mentally ill individuals who are episodically violent, they're just going to say it's ridiculous. Their denial, a good psychotic defense, is obviously going to overdetermine their rejection of any help, assistance, any overtures that you might make, in their behalf. Medication clearly can be very helpful to a lot of these people, but if they don't trust you enough, they're not going to take your advice, and either their degree of dangerousness will worsen, and then you'll petition the courts, or in fact they'll remain in the hospital in an unmedicated state with the consequences, of that. Obviously, I think that all of us have a mission, and I think this is the second question, the role that staff plays in establishing sort of a new value system. I think that's what psychotherapy, and however you define it, is acceptable to me. That's what psychotherapy is all about. That our job is basically to, in part anyway, give patients a corrective emotional experience so that they can start to experience some of their affects, but perhaps substitute now new ways for channeling the frustrations from yesteryear, and not necessarily just repeat the old habits, which for many of the people we're talking about results in violence toward staff, violence toward family, violence, violence in the community. So that eventually, if they have a good enough relationship with any one of us, they then eventually want to problem solve in ways that clearly we encourage and promote. We don't go around, most of us, hitting people, when we get frustrated. And eventually, out of the relationship comes some willingness to, in fact, delay gratification, which is perverse in the lives of violent individuals, but to try, different ways of getting needs gratified. And I think staff, obviously, just by their presence, by their availability, and eventually by their serving, in some respects anyway, as role models, in fact, do wittingly and unwittingly substitute values when the value, and that's really the thrust of my paper, the value often is around the violence and the demonstration of the violence. I think ideas to increase patient frustration tolerance, I mean, obviously decreasing stress, I think that too is what it's about, especially within the institutional setting. And there's no question that we know how to do it either way, that we know how to make a bad situation worse, and I think we know very often how to make a bad situation a lot better, and it has an awful lot to do with the way staff basically interact with individuals. I think before I get to my paper, the clinical interview, very important, and some of this for many of you I know is very, very elementary, but very, very important to take up the topic of violence immediately. People say that you don't deal with transference until it's in the way. My own point of view is that transference is in the way before you meet the patient, never mind during your initial interview with the patient, and that the past, the present, and the transference are always operative from the get-go. And if certain behaviors like violence make you uncomfortable, and you know, or at least it's my hypothesis, that our patients know that violence is making you uncomfortable and it's making them uncomfortable, it's very important in the very first interview to address that. Is it safe for me to talk to you? Or later in the interview, you're getting very upset. You're giving some feedback that you're observing the growing degree of tension, and maybe that's around certain issues, specifically in the history, as you start rambling through history, if that's your approach. But if you don't notice that there's a growing degree of tension, and if you then don't address it, and invite the patient to stop the interview, or at least negotiate with the individual whether the interview will continue, I think you'll find yourselves getting into a lot of difficulty. On the other hand, the majority of patients are very responsive and, in fact, will say, yeah, I'm getting upset, but you're all right, doc, don't worry, I'm not going to... And even to say, look, are you going to hit me? I think it's very important, even though maybe that particular statement is an overstatement of what is likely to occur, the fact that the patient hears you kind of validating the reality, the experience of what's happening, in the interview. Later on, you put it in some perspective and you begin to relate it, to the past and perhaps some stressors, in the present. But the interviewing process itself, in my opinion, is the most useful way to really keep yourself safe. When I first got to Bridgewater in 1986, I was asked to try out Max 1. They had trouble keeping a psychiatrist on Max 1. It was considered one of the more dangerous units. And basically, my very first day, I said, sure, I would get I'd get to the hospital at 7 in the morning and I make rounds. And I would get a cup of coffee and I'd the men really aren't up until about 7:30. So usually the first half hour I'd sit with the nurse, go over the orders, any changes in orders or renewals, that kind of stuff. But then I'd get a cup of coffee and I'd kind of wander around the unit saying good morning to the patient. Well, first of all, the officer culture at Bridgewater is sometimes very antagonistic toward the whole clinical process. And they'd always kid me that I was stirring up the patients. And to this day, I don't understand how saying good morning is stirring up the patients. And further then, I would say to these patients, how you doing? Did you think about what we talked about yesterday? Yesterday I recommended maybe you try some medication. Have you given that any thought? Are you as upset today as you were yesterday? Your birthday is next week. It's important to pay attention to those things too, birthdays and the like. Your birthday is next week. How do you feel about that kind of thing? But the fact that I was going on to the unit with a cup of coffee and just basically mingling with the patients, well, I tell you, that created quite a stir. I still do it 6 years later. I refuse to stop, but I was told to stop. I was ordered to stop. I was told that I was incredibly self-destructive. I was really treated almost as though I were an impaired physician who just didn't know that this was Bridgewater State Hospital and not, say, McLean or some other higher class facility. But anyway, what I tried to help people understand, and 6 years later, I can't say I've succeeded yet, but is that my willingness to kind of talk to the patients in this casual, informal way, in fact, kept me safe. That the opposite was true. That it was my willingness to go out on the floor and say good morning and how you doing kind of stuff. And I'm not talking about complicated, psychoanalytic interpretations, although I do use a lot of those too and feel that they are much maligned these days. But we can talk about that later, perhaps, with some questions. But it's the fact that I think I have made myself available in that way that has kept me safe. Now, that doesn't mean it's going to work for everybody, but there's no question in my mind that I have been able to cultivate a good relationship with a number of bad actors, in part because I've been kind of very willing to kind of go up to them and say, good morning, how you doing, blah, 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 So I think that is very, very important and not funded these days, not respected these days, but if you don't pay attention to the quality of the relationship, you're in trouble. And now perhaps what I'll do is just read you sort of my more formal comments on how I have come to understand what violence means in the lives of a number of patients who have been violent. And here again, it's very important in terms of the therapeutic task to understand what it means to these particular patients, because if you don't understand what it means to them, then I think you can't, for example, establish new values. Because if violence and whatever accrues to them as an outgrowth of their violence, and I'm not talking just about secondary gain-related issues, although those are important, then you can't help these people basically then to substitute a new value system for the old one, because nobody will obviously change unless they feel they're changing for the better. So what I've done, and it's actually a title that my wife suggested, is I've written a short paper called Violence as a Form of Social Contact. And again, I'm not talking about the mafia. I'm not talking about crime on the streets. I am talking about violence that unfortunately is a part of the life of many chronic mentally ill individuals. Very clearly, violence and mental illness do not correlate. And I think that's important to remember. Studies have been done that clearly show that the mentally ill are not more violent than the average member of the general population. Nonetheless, though, violence may be a symptom of mental illness. And when it is, it may be useful to study its meaning in the life of a violent patient. For some, violence may be a form of social contact. And when this is the case, and this dynamic understood, a range of interventions become possible that can result in a marked decrease in dangerousness. This paper studies violence in the lives of a number of patients who have been sent to a maximum security prison hospital because of their violence, Bridgewater State Hospital. This paper suggests that once patients begin to understand the role of violence in their own lives, they are able to substitute other behaviors for the violence and achieve a more successful adaptation through nonviolent verbal and behavioral means of problem solving, that in fact they can acquire a newer value system to replace the old one where violence is so central. Now, violence has often been studied, and studied in hospitals and studied, in the community, but the studies really don't, at least the ones that I've been able to discover, don't really look at it in terms of the process, sort of what's going on, what the communication may be around the violent behaviors. So there are lots of articles, and I won't bore you with the review of the literature, but around seclusion and violence as a function of crowding on units, et cetera, et cetera. Only a few studies have attempted to examine the meaning of violence, and these usually seem to emphasize the role of limit setting and attempts to appeal to a patient's positive personality characteristics. Violence as a form of social contact has not been suggested in the literature. A thoughtful evaluation of a patient's violence, especially when the evaluator is able to have an empathic approach which conveys thoughtfulness, respect, and a genuine wish to understand and help the patient understand, can lead to a cessation of violence while the patient begins to develop some insight into his behavior. But again, I don't want to be misunderstood. I'm not talking about being foolish either or being naive either. I mean, you want, I think, to be perceived by your patients as empathic, which has something to do with a genuine willingness to kind of understand what life looks like from their shoes looking out. That you're there to try to understand basically what their pain is all about. But you also have to understand that certain people are not in good control, sometimes certain people are not so nice, and you can't be foolish as you broadly apply a kind of an empathic approach at relationship building. Conveying to the patient that you are interested in the meaning of violence in their lives while gently establishing ground rules for the evaluation to continue helps to diffuse many tense situations while enabling the patient to function more successfully in his environment. And again, just to repeat, I think it's very important to say to these people, you have a history of being violent. Am I likely to say something that will upset you to that extent that you might get violent? Or I sort of observe, I see that you're getting upset. Apparently you don't want to talk to me about your mother or your father or whatever the situation might be. Should we continue? Would you like to take a recess? And basically develop the ground rules for continuing if in fact it's safe to continue. 99% of the time the patients are eager to continue, will assure you that everything is fine, and you in fact do continue, I think, in a useful way. In my opinion, the greatest majority of patients do not like to lose control. They find loss of control very dysphoric and at times humiliating. They will often then appreciate your willingness to study their violence as a hopeful chance to avoid loss of control. Within a hospital setting, a number of patterns and meanings to violence have been defined, and these are going to be discussed now in a number of vignettes. First, violence as a defense against sadness and depression. Quote, "Why stay out of trouble? It enriches me," end quote, says one violent young man. And maybe this is kind of what Jesse Jackson was referring to when he talked about jail being a step up for so many people. Life is tough for a whole lot of people. I think it's lonely. It's hard to figure out where your meals are coming from. You feel very alienated from family, far more acutely when you're in the community away from them than, in fact, when you're in the hospital away from them. And I think the violence somehow is an outgrowth of that very often. This particular patient's life is one long tale of impoverishment. Another suggests that his reputation for violence, without it he has little else. Through his violence, he can avoid dealing with his feelings of how little he's had throughout his life. And here, putting it in a kind of historical perspective is very important. And I think the sooner you can begin to do that without being perceived as fleeing from the here and now, I think is a useful strategy. And he can really sort of blame his violence for the impoverishment of his life, and also hold himself responsible for the impoverishment of his life. So here he can thwart really his own grief process in terms of dealing with the disappointments and I think a profound rage at caregivers along the way, parents, relatives, teachers, whoever, who in fact have disappointed him. Somewhat like Alice Miller suggests, that it's so much easier to blame yourself than in fact to start dealing with your disappointments and your anger toward people that in fact were supposed to take better care of you when you were growing up. Depression is avoided as this particular patient experiences his isolation as the direct outgrowth of his own actions and not relating at all to his past. Another patient lives his life in a rage at teachers and healthcare providers and is at times very assaultive. He will rage at teachers and in so doing avoid completely coming to the realization that it was his parents who sent him away at the age of 9 and not the school officials. He protects them, his parents, and his memories of them in the service of avoiding his unconscious feeling of rage and disappointment at them. And this is really kind of an Alice Miller formulation. His violence serves to enable him to avoid depression. Through psychotic denial, a patient defends against his own ambivalence by maintaining that the woman he killed is an imposter and not his mother. One patient summarized this dynamic very well when he commented that, quote, "We don't feel grief, we give it." This also suggests that violence can be a defense against passivity in the service of mastery, and that's the second sort of clustering of dynamics. Violence in the service of mastery and omnipotence. Quote, "I can do what I want because I'm a criminal." These are often patients who have experienced considerable shame and humiliation, and now, because they are criminals, have permission to act out their revenge through violence. Unfortunately, their targets are usually the wrong ones, and the good feeling generated by action after years of passive helplessness is very short-lived, and often accompanied by further shame and humiliation. Like Richard III in Freud's essay, The Exceptions, about, wonderful essay on kind of entitlement would be the sort of more modern-day formulation. He's able to do anything he wants because rules and regulations do not apply. When feelings of shame and humiliation are stirred up, any behavior is acceptable. This patient felt justified assaulting an officer because he felt he had been humiliated through an insult. As children, many of our patients have felt totally helpless in the face of overwhelming abuse, neglect, and shaming. As criminals, they're able to become active in the service of acting out their self-contempt and their conscious and unconscious wishes for revenge. 3. Violence in the service of achieving identification and persona. One psychotic and violent young man boasts that they, quote, auto-naturally know me, end quote, in neologisms. Another patient wavers between depression and feelings of worthlessness and omnipotent feelings of being a legend in his time. Through his reputation that he's achieved through violence. Well, just a patient that was admitted yesterday who clearly is down and out, you just look at him and you know that he's a long-suffering soul. He has a psychotic delusion that because he had been masturbating in his own automobile, that he's now on the FBI's most wanted list. And there's that TV program now that he's been highlighted on one of those TV programs. Well, that's clearly wishful thinking on his part, that he's achieved such persona, such standing, such recognition, because he really feels, and it's very apparent later in my interview of him yesterday, that he very much feels like a nobody. For a long time, this is back to the patient in the paper, he was considered one of the hospital's most dangerous patients. Everyone knew him, and wherever he went, his reputation preceded him. And he's actually, I interviewed him on tape, and if we have time, we could hear excerpts of that. But the word was, don't ever turn your back on him. And this was repeated wherever you went. He's one of the people I would have coffee and go up to and say, hi, how you doing? Through violence, he was, oh, and actually I did something else with him. I finally developed a little humor, you know. I sort of asked him if he was brewing a hate. And that became a kind of a little thing now. Years later, are you brewing a hate today? And he'd laugh at me. He said, no, are you? You know, kind of thing. Through violence, he's a somebody, and without it, he feared that he was a nobody. And really, without his psychotic delusions that drive, you know, his violence, he is, in fact, now, I think he's 42 years old, really without a life, without a support system. Not someone that's going to spend a lot of time in the criminal justice system, unless, of course, he keeps repeating, and, of course, he'll keep repeating because it's better than life, you know, in the community. One patient reports that about another, that he, quote, is someone here because he gets a lot of attention, and he will lose this if and when he is transferred. So, you know, a nice piece of insight from one patient about another. This patient suggests why violence may be a behavior that is difficult to give up because the fear is that status and need gratification will be lost. And I'll tell you another brief anecdote. We conferenced another patient who is very proud of the fact that he spent 9 months in the community. He lived in a single-room occupancy. This is a man who has spent, prior to that, 13 years in jail, in prison, and pretty much since age 11, he's been more or less incarcerated. But for 9 months, he was in the community. But his life in the community was a single-room occupancy. He got SSI. The room cost him $65 a week. So if you multiply that by 4.3, it leaves you every month with enough food for a week and a half. And basically, after 9 months, I think his depression caught up to him. And he repeated. Although he's proud of the fact that the crime he committed this last time that got him into the correctional system was not a violent crime. The car wanted to be stolen. Someone just left it there with the motor running, you know, that kind of thing. But his prior, it wasn't an armed robbery. There was no potential for anyone getting hurt. And he's very proud of that fact as well. But basically, he solved his dilemma of aloneness in the community by getting, you know, like Jesse Jackson said, coming back home. For different reasons, persona issues, and see, he had none when he was living. He was a nobody in the community, and I think that's really his tragedy. For different reasons, persona issues can become macho confrontations that cause situations, especially in the hospital, to escalate into really what are avoidable violent struggles. A man, for example, is confronted over his fairly appropriate request for a towel, and a rookie officer barks back at him. He barks back at the officer, and before you know it, there's a kind of a hostile approach. He takes a swing, and he's locked up for that. A fight ensues that quickly becomes very violent, in part because now the culture sort of reinforces that if you're going to be taken out in front of your brothers, you got to go out like a man. So the situation has already gotten very well out of hand. Another patient spent years cultivating a reputation of being a very dangerous man. He was considered by some to be an animal, quote unquote. And long after his violence had stopped, the reputation persisted. He clearly took pride in this persona and fostered the reputation of making weapons. He never used them, though, for the last 10 years. He didn't use the weapons, but he'd make weapons. He'd leave them alone in an empty room, and he'd make 15 weapons. And he'd hide them, and nobody could find them. And then every once in a while, he'd drop little clues as to where these weapons were. And these were good weapons, you know, that certainly could have hurt. But he was able to substitute the higher value of just making the weapons and didn't feel the pressure because his reputation preceded him and persisted, didn't feel the need to use those weapons. His violence years later became a fascination with weapons making and their concealment. This process now made him feel good about himself. It was as if nobody had ever taken pleasure in his intellect and his skills, And we kind of marveled at his ability to make these weapons. I mean, literally out of thin air, it would seem at times. Actually, as we began to marvel over this skill that he had, in fact, he became far less violent and much more personable as well. He was not in seclusion for years prior to his discharge from the facility. As his relationship with staff then began to flourish, and as the weapons-making behavior was interpreted to him, it stopped, and he began to apply his energy to his therapy, believe it or not, and to discharge planning. It's not altogether a happy story, though, and if we have time, I can give you a couple of year follow-up on what happened to this man in the community. 4, violence to establish one's sense of self-boundaries. Now, remember, we're talking about chronic mentally ill people who really, if they're not actively psychotic, seem to have a predisposition for psychosis. Boundary issues are clearly very important. One patient was clearly in the midst of a profound psychotic regression and was obviously very stressed out. He appeared to be losing his sense of self as he became more psychotic and more panicky. I mean, we'd all agree he was panicky. It wasn't just a kind of a subjective observation. He was losing his boundaries, and he complained that he was not sure where he stopped and others began. He intruded several times into the staff meeting room, and he was abruptly told he'd have to wait his turn. Our mistake. He could and should have been invited to sit down right away in acknowledgement of the obvious terror that he was experiencing but also manifesting. When he was told to leave in a very confronting style by a staff member who was clearly provoked by the intrusiveness, you know, we don't like to lose control of the situation by having patients basically intrude and tell us that they need to be seen. He began to assault, and a very violent encounter followed. The violence paradoxically enabled him to calm down completely. And as if it helped him establish boundaries as limits were set, and he was subdued by 6 officers. This event marked the end of his regression and the beginning of his recovery. Another patient was confronted with the observation that his fingernails were too long and dangerous and that they had to be cut. The symbolism of his body parts, especially in an obviously psychotic and violent young man, was totally overlooked. And through the confrontation, you must do this, in fact, a very violent struggle followed, and in fact, he used his nails to scratch the face of a mental health worker. 10 minutes later, when he was given an opportunity to talk about the symbolism of each nail, this is my uncle, very psychotic, but very important to him, he was then able to cut his own nails under supervision, which he agreed to do. Believe it or not, we did subsequently get a court order to cut his nails, but it's much more efficacious to try and kind of negotiate with him to get him to do it, rather than to kind of force the issue. And I think this kind of confrontation, we really have to watch ourselves, I think, because a lot of these patients are masters at provoking, and we have to be careful that we do not get provoked. We all get provoked. I mean, we are obviously human, but I think we have to know ourselves well enough to know that certain things rub us the wrong way, and we behave in certain stylized ways when we are rubbed the wrong way, but it can lead to tragic consequences. A number of years ago, a psychiatrist in Massachusetts was killed because a very psychotic young man stormed into a state hospital looking for his therapist, and somehow or other got into a room alone with his therapist, who was a resident, a psychiatrist in training, and held the resident at bay with his gun and actually took a shot at him and clearly missed him. And the psychiatrist who got killed stormed into the room and said, "Put that gun down," and got shot. You know, it obviously was one of those tragedies that you never forget. But in retrospect, one wishes that perhaps different strategies of intervention had been thought about before this explosive intrusion into the room, which I think freaked out the patient so much, that he turned the gun on the intruder and shot, and unfortunately hit him, in the head. Maybe that's a way just to make the point that I think that when we're rubbed the wrong way, or we feel the situation is getting out of hand, sometimes a little kind of a slower, a thoughtful intervention may be more helpful. When the fingernails were later discussed and his psychotic delusion about them were defined, he became very agreeable to cutting them, and has pretty much been cutting them now on his own for the last couple of years. Each represented a family member, and all reflected his marked ambivalence toward each of these family members. Only when this was understood did he become willing to surrender the nails without losing control. They were a somatic defense against a murderous rage, and when this was addressed, he could give up that particular defense. This particular patient is also a very good poet, and he was encouraged to express himself more through his poetry. And I often use him. I'll invite him to come to a teaching conference, and at the end I'll ask him to read a couple of his poems. And his poems are really quite poignant. He agreed once he realized that staff valued the poetry as a means of expression. An assault upon his fingernails, perhaps related to castration anxiety, threatened him with personality deterioration, and he had no choice, I think, but to fight back. For different reasons, violence may define one's identity and one's job. Now here I'm talking about staff. And without it, there can be role confusion and anxiety. This is a sort of a subject that you can get into a lot of trouble, particularly in my hospital, by raising. If you really suggest that sometimes the officers or perhaps clinical staff as well contribute to some of the unfortunate occurrences, people feel you're blaming them, and really they get very angry. Nonetheless, it's important to kind of process situations. Without violence as a daily occurrence, staff within a correctional facility may come to feel like displaced homemakers prone to depression and acting out. The culture needs to redefine job norms and establish new norms for what behaviors are valued. In a psychiatric hospital, violence needs to be replaced for staff and patients alike with verbal modes of frustration resolution. This is a complex task that requires staff to do their homework so they can own their own depression and feelings of failure. Staff will too often identify with a patient's negative attributes and act this out by fostering violence in the service of avoiding those feelings. Who would call a patient a piece of shit, quote unquote, other than someone who is prone, perhaps unconsciously, to feeling that way about himself? If a patient, and it's just like mother jokes, you can't have any mother jokes at our hospital, and if you want to get hurt, just go up and say, your mother's a, Now, I have found that always an interesting kind of communication, because obviously 100%, at 99% of the time, the person who's saying this to the other patient doesn't know his mother, never met his mother, has no idea whether his mother is a mother effer, or whatever, has no idea whether she's royalty or an awful individual. But the reaction that kind of the mother jokes evokes, I've always found it very, very interesting, because clearly, if someone says something to me about my mother, I'm not going to punch them, I'm not going to like them necessarily, I'm not going to agree with them. But if I have a profound degree of ambivalence toward my mother, and you say something to me that I've been spending my life avoiding, I'm probably going to hit you. So there are no mother jokes, and I think it's interesting to wonder sometimes why there are no mother jokes allowed in a correctional setting like ours. Similarly, if a patient ought to be given a, quote, a silver bullet, which is a joke among the officers, that's the therapy of choice for this patient, a silver bullet. It really suggests to me more about the officer in this particular case saying that than it obviously says anything about the patient. And my guess would be that if one had an opportunity to kind of do a psychiatric evaluation on the person who's saying the silver bullet is the treatment of choice, you probably often would be talking about someone who grew up feeling that they were in the way, that they weren't welcomed, that there were things about their own growth and development that were sparse. Institutions too often make available the poor and the powerless as a focus for projective identification to enable the more powerful to act out their feelings, and in so doing avoid their own sense of inadequacy and depression. And one more anecdote. Bridgewater, the whole question of sort of who owns Bridgewater, who makes the decisions, the clinical versus correctional, and the cultures are obviously compatible if one wants to perceive it that way, but they're incompatible in the eyes of many. And anyway, on Max 1, we had a ping pong table. And it was never clear to me when the ping pong table was out for the men to use and when it was locked away in a storage room. There was no rhyme or reason to it as far as I could tell. But, you know, over the time, I mean, I have an agenda, you know, and as far as I'm concerned, everything is clinical, and eventually lots of decisions that were being made by correctional officers really were clinical and should be made by the clinical staff, including the goddamn ping pong table. Well, once we started to make our move on the ping pong table, it got broken. Well, months later, we lobbied successfully to buy a new ping pong table, to get a new ping, and we got a brand new, wonderful, I like to play ping pong, obviously. My wife reminds me that I won a ping pong tournament at Boston State Hospital against a schizophrenic who was on 1,600 milligrams of Thoracin. It's true. Although I didn't raise his dose the day of the tournament. But anyway, so now we have a brand new ping pong table, and we more or less have established that the clinical staff will decide when the ping pong table's out, and more or less it's established that the ping pong table will be out all day. You know, well now, don't you know, the officers won't give the patients ping pong balls. So, you know, it's kind of one thing or another, but I think if you just keep trying to solve the problem, so then you sort of, you know, then it'll be the ping pong paddles, and then, you know, then the table will get broken again. If you don't appreciate, I think, the dynamic that's incorporated in that little struggle around the ping pong table, I think you'll be kind of missing the point that the officers, maybe it's true for clinical staff as well, kind of get into a struggle with patients where they tend to see themselves more like the patients than in fact, like part of the Army that's mandated to take care of these people. 5, violence as a defense against boredom. And I think this is important. Patients are, when they are incarcerated, often crowded into limited spaces with limited activities. And this is true for a lot of state hospitals, maybe not new ones that have been built, you know, with JCAH constraints in mind, with some extra space and, you know, I don't know. But boredom, even within better facilities, is a problem and can at times foster violence as a means of breaking up boring routines. Now, this is not a very deep interpretation, but I think it's an important one. Boredom can foster a regression and result in the emergence of more primitive thought patterns that result in reality distortions, paranoid feelings, and an accompanying need for self-defense. Violence is often the result of primitive thought patterns that surface when people lose their sense of identity and self-worth. I've been fortunate lately in working with some wonderful officers who very quickly will give patients jobs. And it's incredible how some of these more violent patients, when they get a job, are no longer violent. You know, they have a nice outlet for some of their energy. Richard is lucid and goal-directed during a ping pong game, and when asked to do a work detail on the unit. At other times, he's aimless, very agitated, grossly delusional, and often very assaultive, and didn't respond at all to Clausewell. When activities must be canceled because of staff shortages, and especially during bad weather when patients are confined to the unit or the ward, the level of tension and violence increases dramatically. Many patients, especially most with an Axis II diagnosis, use the character defenses to deal with strongly ambivalent feelings. The principal defense for many is acting out, and when meaningful outlets are thwarted, the level of violence increases. J.W. sits around, often looking menacing. He has a long history of assaults in response to psychotic distortions. When given a responsible job in the unit, he becomes very interactive, pleasant, and never even comes close, it seems, to being violent. Also, he became able to discuss his previous assaults and indicated some interest in learning about what happened to him each time that caused him to act out with violence. Really developed a kind of a, I'll say, observing ego. It's probably a little over strong for what happened, but some curiosity about why he did what he did. 6, violence to discharge sexual tension, frustration, and counterdependency. Many assaults within the penal setting occur because someone believes that their manhood is being challenged. Many men react with violence when they feel disrespected, when they're dissed. But rarely do they understand what that experience is all about. The all-male environment, especially when activities are limited and space very confining, can be a stimulus to dependency longings, regressive. Many patients, after years of childhood abuse and/or neglect, are counter-dependent in their lifestyle. When forced to be dependent, and that's often what we do when we institutionalize people, they become anxious, especially as dependency yearnings are stimulated. Homosexual advances will stimulate conflict, and because of ambivalence, often results in a display of violence. The advance may be experienced as a sign of disrespect. One patient felt ridiculed and, quote, dwindled, end quote, when he felt others were making fun of him. Sexual tensions have pre-Oedipal as well as Oedipal derivatives. The pre-Oedipal factors have to do more with dependency and wishes to be cared for, wishes that are unconscious and far too painful because of the earlier frustration secondary to the abuse, and which have to be defended against at whatever the cost. And violence may be the response as well as the defense. Oedipal sexual feelings may also contribute to the tension within the milieu and be the reason some men approach others for sex in a setting that obviously precludes heterosexual relief. Privacy, opportunities for discharge through activities, and especially competitive interactions, something I think men find very important, and milieu groups, group meetings that permit some of these issues to be defined and discussed can all help minimize the sexual tension that may charge up the milieu. Certainly, it's very important to give patients the opportunity to talk about the many ways they disrespect themselves and to explore the historical antecedents for their low self-respect and self-esteem. Their vulnerability to feeling disrespected is often central to understanding their violence, and most patients can and do want to learn about this. Medication may also be useful in helping some remain in control of their feelings, even when the milieu is intense and upsetting. Just a few closing comments. In suggesting that clinical violence can often be understood if its meaning in the life of the patient is studied, I'm not suggesting that violence be condoned and that perpetrators be allowed to avoid punishment for breaking rules and at times for breaking the law. Therapy begins with patients taking responsibility for themselves and their own behaviors. Taking responsibility, however, does suggest the need to understand what leads up to the violence. Patients do not like to lose control, and many do not understand why they do. Many can give manifest here and now justifications, but these explanations often lack, obviously, sophistication and an awareness about stressors and why stress may lead to violence. Surprisingly, when given an opportunity to study their own violence, many patients will become very curious even after initial sarcasms, dismissals, and sometimes overt hostility. The chronic mentally ill, especially those in the criminal justice system, have a real problem in acknowledging and then bearing their feelings of sadness and depression. You know, to acknowledge, to bear, and put in perspective. For many of us, that's what psychotherapy is all about. They act out to avoid feelings. Some give grief to avoid feeling grief. Others work hard to be in the active mode as a means of overcompensating for periods of time in their lives when they were shamed and humiliated. Others feel anxiety around identity issues and through violence come to know themselves by observing how others see them. Violence during a psychotic regression may be a desperate means of establishing boundaries and preventing further loss of self. Boredom can foster regression and lead to violence, especially when the discharge of energy is precluded, And this is very timely during Rehab Week because I think most of us certainly appreciate the very important role of rehabilitation in the overall recovery for the chronic mentally ill. Boredom can foster regression and lead to violence, especially when the discharge of energy is precluded and patients have little or no way of feeling creative. And for all of us, that's very important. The buildup of sexual tension when counterdependency defenses are thwarted also leads some patients to violence. The therapeutic relationship is the medium in which patients can study their own violence. A relationship is possible with individuals, with members of a treatment team, with correction security staff, with legal staff, with the secretary in the library, and also anyone who takes an empathic, interest in the individual. The patient must not feel judged even as they are taught about limits. Treators must be around for a time to allow for testing, some acting out, and the slow emergence of trust. All this can occur through milieu treatments, recreational activity groups, group and individual therapy, and through a variety of formal and informal interactions that patients have with all staff, like a ping pong game. Gradually, patients can learn about their feelings and also new values that are shared by other patients and members of the treatment staff. When violence is discouraged, as it is studied, and newer values are put forth, behaviors can be tailored to fit in better with the newer value system. Patients are often very object-hungry and will adapt their behavior in the service of having some of their object needs met. With time and sustained relationships that are fostered through nonviolence and that are put in jeopardy through violence, patients begin to have corrective emotional experiences that enable them to internalize the newer tolerance for frustration and the newer values that now become linked to need gratification. As this process unfolds, one can see patients relax, become more interesting, which I universally experience, and certainly become much better in control when stressed. Patients can and do take pleasure in feeling good about themselves as they develop new styles of nonviolent behavior. So, some questions. I don't think I'll play the tape, but it would take too long. Yes.
You suggested that a staff member could diffuse a violent episode, so they play a primary part sometimes in that interaction. I'm just wondering if there is some training that is really effective to help staff members understand exactly what behaviors they are exhibiting along with the client.
Do I believe, I was asked to repeat the questions, that staff training obviously could make a difference in terms of the overall management of violent patients? And obviously, yes. I mean, I think that that should start before your job begins, but clearly every time there is an incident, particularly a violent incident, as painful as it is, it's kind of like, the suicide autopsies that you do. I really think there should be an honest, open processing of what occurred. Mr. L, for example, I mean, we botched that case. I'm almost embarrassed, but not enough. But he is a man who is big. He's very violent. But when he decided to manipulate the system to come to Bridgewater State Hospital, he made a decision that he wanted to try some treatment. Anyway, to make a long story short, the officers did not like him, and they were riding his case. They were they really were giving him a hard time. Nonetheless, he was maintaining very, very good control. And during a treatment team meeting, after there had been a fairly violent lockup, and this is now a day later, and he's back on the unit, he's basically talking about why it bothered him that he had been accused of doing something, and I wouldn't do that, and he's kind of with his finger, and his voice is getting louder. But he was sitting in his chair, and he was gesticulating with his finger, but he was doing nothing untoward, nothing that would indicate that he was just about ready to explode when 8 officers rushed into the room because the volume, and he was sitting in his chair, and all these officers came rushing at him because they really, were on his case. And they backed him into a corner, and he picked up a chair, and then he put the chair down, and he kind of looked at me helplessly and just sort of, shrugged, and he was taken off to seclusion. Now, I think there's a situation where I think the clinical staff, myself, I should probably have realized that his voice was getting too loud for the culture to bear, not for me to bear, not for him to bear, but so I think some training in that area, had I stopped the interview, or, for example, had I simply said, you're getting louder and louder, are you okay? But I didn't do that. I was nonplussed also because the officers were watching. Usually we have one officer with us who's a member of the treatment team. It's the sergeant. And because this man had such notoriety, there were 4 officers in the room. And then the whole way the officers treated him. I mean, he's not the kind of man you confront. Reminds me a little bit of Mr. B, the man that I would bring to mass rehab once or twice a year. He was this very proud, violent young man who had actually been arrested with a charge of murder. This was after I had been seeing him, and spent 18 months in the Charles Street Jail, which is now closed, but was subsequently exonerated. And in part what happened is his girlfriend and another woman got into a fight in a bar room, and he came and sort of pushed them apart, pushed his girlfriend to the left, and this other woman, she went home, not his girlfriend, the other went home, told her brother. Her brother came back to the bar with a small army. They had chains and bats, but they backed Paul into a corner. And Paul was like this in the corner, and there was a knife that he just happened to reach. And the first person that came after him, who happened to be the brother, got the knife, died, and it was self-defense, and he was let go. But 18 months of his life spent in the... But he used to come and tell people, this is what you don't say to me. If you want to help me maintain control, don't say the following things to me. So I think that the same with the other patient. I think had the officers kind of backed away and let us just finish the interview, an enormously violent struggle would have been prevented. So yeah, I think in-service training is important. But the people, I said to Roberta when I arrived, I wish I had thought to have a patient here to start, the presentation with, because really the patients are the best teachers, and they'll give you the in-service training if you're open to the experience. But I think open to the experience has something to do with establishing the right kind of tone in one of your early assessments, one of your early interviews with these patients. Yes, Chester.
If you're dealing with patients on a long-term unit and at the time they're on patient is not being violent or might have violent history, is it possible to use a type of psychotherapy to work on ego development or moral development as a way of coping with individuals?
Well, I want to say yes, but I think I don't know exactly what you mean. You don't want to necessarily develop an intervention through the superego, because I think it's important to remember that most of our patients sort of have such overly developed superegos that ain't the problem, so that they don't respond to lectures. That's why they can't read a book and learn about their behaviors. I think they have to be kind of ego interventions that then help them deal with some of the impulsivity and the reasons behind. But I really think our approach to all patients, long-term, short-term, has to be basically a kind of a psychotherapeutic approach. Now that includes rehabilitation, that includes psychopharmacology, but I have really, in 21 years now, Chester, not found a patient, that's not true, 3 patients in the 21 years where we have felt they were better off without us. But in all the other cases, including several very retarded people who were quite violent, who really responded very well to psychotherapy. Now, it has to be an eclectic kind of, you got to take walks, you got to do a lot of things very eclectically, very flexibly, but who haven't been able to learn something about themselves, and in the course of that, not only function in a socially more acceptable way, but in a less violent way. Yes?
I was curious to hear your personal reflections as to why psychiatry is giving up its interest and experience and all this wonderful psychodynamic insight. What's going on in our field and why are we forgetting it?
Well, I mean, Freud was probably, Karl Marx was probably, oh, I'm sorry. Why do I think that the field, it isn't just psychiatry, but the field has kind of wandered away from sort of a more insight-oriented approach to helping people learn about themselves?
The approach that you're using, trying to understand the meaning behind the violence in this case, trying to seek meaning behind behaviors and working with that.
I can only be cynical in the sense that I think, Karl Marx was the first Freudian, and I think, he basically suggested that economics do drive a lot of this, and it doesn't pay. On the other hand, I argue, and I think many people argue, that it does pay, that a stitch in time saves nine, that, in fact, even in one interview, if the patient leaves the interview with something to think about in terms of their past, their present, and their transference complexities, they are better off. But I think that, it always is true. It's funny, a study group that I convened met last night. We were talking a little bit about moral treatment, and every single time there's a medicalization of psychiatry, the quality of care deteriorates precipitously. So during the mid-1800s, with Dorothea Dix and the whole evolution of moral treatment and asylums for the chronically mentally ill, I think there was a quality of care that was exemplary. Then, Freud, others, I think, discovered the brain, and, neurology had its ascendancy, and just the care within the institutions deteriorated substantially. And I think today, with the medicalization of psychiatry around psychopharm, which clearly has something to do with the insurance companies who only pay for, 5 days, 6 days. And what can you do in 5 days or 6 days except give some Xanax so people are happy and will speak well of the hospital when they leave? So, I think that it's been pushed aside with some of the sort of organic treatments that are currently available. And they're good treatments. I don't want to sound like I'm against psychopharm. I mean, I'm a psychopharmacologist, and but again, you're not going to get your patients to take what you recommend if you don't at least develop some curiosity on their part, some interest in control, but some curiosity about why they do what they do. So I don't know why exactly, except I think, psychopharm is really the measure of quality of care today, and that's unfortunate. Yes, sir?
I think a lot of security people are addicted to adrenaline and therefore try to maintain exercise or control.
Do I think that security people sort of get a high out of violence? And I think I was sort of suggesting it not so abruptly as that, but suggesting that, in my paper, that I think there is there's a whole industry that is supported by violence, and that therefore, doesn't necessarily want to see higher value substituted for violent behavior. So yeah, I think that is true. But I must say at Bridgewater, for example, that is true for certainly not, how everything is a third, and a third, for far less than 1/3 of the staff at the hospital who really shouldn't be there. 1/3 of the correctional staff are superlative and really are good at providing security, but have the appropriate amount of curiosity about what does a psychiatrist do and what do social workers do, and really participate in the teamwork. 1/3 are kind of bland and disinterested, and they'll take it, they'll leave it, but they're not committed to it, they're not passionate about it. And I think much less than 1/3 are destructive. And unfortunately, we can only, there are unions, and you can only get so many of them on perimeter patrol and on transportation. You can only get so many of them out of the hospital. Yes?
I have a
And your question?
Is this part of the help?
Yeah. The need for physical outlets, exertion to discharge energy, and is this an important part of a treatment approach? And I think it's very clear. I mean, I jog every day. We've worked very hard on the admissions unit to arrange for our patients to have at least, believe it or not, 1 hour off the unit every day for exercise and/or activity for the discharge of energy. I think it's very, very important. If people just sit around all day with the TV blaring, the admissions unit's a noisy unit. You can't get away from the noise. And there aren't opportunities for people to discharge energy. And I agree with what you're suggesting in your question, that it's very, very important. It's been very hard to establish, just an hour a day off the unit for activity, gym, and that kind of thing. Very, very important, though. Yeah. Yes?
As a person of income, I agree with the exercise. I think it's great.
Yes.
But one of the questions that we had was, in the process of selling, in the process of putting stress and going for violence, of sexual violence,
Mm-hmm.
is it more beneficial to have physical activity during that time, or more calming activities, or what kind of criteria do you have for that?
Well, yeah, sort of how do you decide what the appropriate intervention might be if someone you feel is escalating? Well, I mean, obviously you got to be there, and it might vary, from case to case. But Jimmy was very violent during the early part of his life. Now he was dying of chronic lymphocytic leukemia. He would clearly, you could almost judge what his white count was by how paranoid and outrageous some of his behaviors would be. But it was enormously helpful for him he died, prior to his death, to break a few rules and let him take a walk from time to time. I mean, it was brilliant. To say to him, look, you're very, very upset. Before you lose control, why don't you take a walk? So, I mean, there may be times when that wouldn't be helpful, but most of the time, I mean, I think people, again, it's how you present it, not so much what you're presenting. That if you're sort of giving him the feedback that he's getting upset, he's about to lose control, you're suggesting some willingness to be helpful to him, and maybe your first suggestion is bonkers as far as he's concerned, so you'll go to your second suggestion, and you'll say, well, I don't know what to do to help you right now. Just that process will often diffuse the immediacy, the urgency of the situation. But most people, and maybe, I don't know, I don't want to sound like a chauvinist, but it's true for men, and maybe it'll be true for women too. I mean, you've got to have outlets, exercise, and so many of us define ourselves from our work and feel good about ourselves in terms of our ability to be creative and do things, and I think we can't lose sight of the fact that that's equally important for the majority of the patients, if not all of them, that we encounter. Medications, we really haven't talked. I think the medications are very, very helpful, but only in the context of some kind of a relationship that they feel is evolving with staff. There's no question lithium for young men who are episodically explosive, especially if they tend to punch walls. Lithium in low doses, maybe 300 milligrams 3 times a day, very, very helpful. But if they're not willing, I think Depakine, very few side effects from Depakine, very helpful for people who are episodically violent. Inderal sometimes. Tegretol, of course, sometimes the sort of the seizure, medications. I think we tend today to underdiagnose psychosis. I think we tend to overdiagnose affective disorders. There's a certain kind of countertransference there where I think it's more optimistic to say, well, you're depressed as opposed to you're schizophrenic. But I think there's a tendency to sort of not see psychosis when it's there. And we rarely are seeing people who aren't partly medicated so that, everything is skewed. But if someone is psychotic and dangerous, the best treatment in the context of a relationship is to give an antipsychotic. And then eventually wean them from the antipsychotic perhaps and put them on, or at the same time put them on something that might be useful for their violence. But again, you're talking often about a younger population, a male population in my case, very proud, macho, medications for sissies. And if you don't really sort of prevail in terms of getting through their ego some willingness to sort of, try it out and see if it might be helpful and not to feel disrespected by taking a pill, you're not going to get them to try anything. Another question? Clozaril, I don't know what I'm doing wrong, but I have not had good results with Clozaril. I wish I could say the opposite was true. In the outpatient clinic where I'm responsible for about 160 patients, we just have not been able to successfully get anyone on and off Clozaril with a useful gain. In the hospital, we've had about 8 or 9 people on Clozaril, and one, maybe 2 cases where the results, they seem to be doing better, but even that's an argument, so in a sense, the results have not been, they've been very disappointing. And maybe that's demographics in the population I work in, but the results have been very disappointing. Yes? Are there any hormonal disorders? Well, we like to think that we're giving patients a comprehensive assessment and ruling out, obvious problems with thyroid dysfunction, for example. I think that again, very rarely do we discover kind of organicity. Now, HIV and the kind of, I don't know why it's called a dementia, because it's not a dementia, but the encephalopathy you see with HIV, that clearly is very important. That's not hormonal, though. And then the use of hormones, for people who are violent, there are a couple of patients who have asked for hormonal treatment as a therapy. And in a prison population, it's very controversial, and the literature is very controversial anyway about whether it's helpful or not. When I was at APA, I asked somebody who was supposedly an expert, and he said it's definitely helpful. So maybe we need to try it from time to time. But again, in a population of involuntary patients, it's tricky to be offering something that isn't really FDA approved, and for that. One more question? All right. Well, thank you. Good luck.